Hi everyone, it's Dr. Matthew Leonardi here, and it's great to be with you for Endometriosis Canada's Awareness Celebration.
Hi there. Thanks for joining us today for our annual Endo Awareness Celebration. Today we have Michelle from the Happy Pelvis with us. Hi, Michelle.
Hi, everybody. Really excited to be here. Thanks, Vicky, for having me on today.
Well, we're lucky to have you with us. We will also be having Dr. Vidali join us halfway through the program for a live Q&A and for an informative session on out-of-country care for those that are interested in their other options that they have to learn from. um, Such as myself, I had to go out of country, and that is why this whole support group began 10 years ago because of not having anyone around that understood, even not being heard by my doctors. And my only regret was not getting care sooner. And so that is why we are going to be giving people just experiences from Dr. Vidali and more information in case they are looking for that option, because I know in Canada it can be very difficult to get care if you have endometriosis. Did you want to share your experience with endometriosis?
Absolutely. Hi, everyone. I'm Michelle again. I'm a Pure Health Navigator and a patient advisor with Ontario Health in my province. I'm a passionate pelvic health advocate, as well as endometriosis advocate and the face behind the Happy Pelvis. And my endometriosis journey started in my teens. And it took me many, many years to get to the point of frustration with our healthcare system that I began to really advocate for myself. And it took over 15, 20 years to get a diagnosis. After years of suffering, many ER visits, many dismissal by doctors saying that it's not endometriosis, you're fine, it's IBS, or it's just chronic UTIs. And when I started my journey on this quest to find answers, I found support groups like Vicky's support group on Facebook. And that's a spot where I found a lot of information about specialists within my area, in my province. So I'm forever grateful for communities like this who are out there supporting patient voices.
Oh, thank you. That's so sweet. Because we try to aim for building community so that everyone knows that they're not going through this illness alone. Because without seeing everyone online, if you don't know anyone else going through it, you can feel alone, because even the people that love you, they don't understand just how bad the pain can be. And many don't have, like, they don't believe you that you're in that much pain, and they think that you have to suck it up. Even doctors sometimes don't believe us. So we need each other and to help make each other stronger and to share information with each other about like the experiences we have with doctors or with medications, and just to be supportive and to be there and be a friend for each other.
Absolutely. And I'm all about providing resources, support, and guidance to help people and folks like navigate their own diagnosis because all of our bodies are different. It's not black and white. So I help people communicate better with their healthcare providers and really help them make informed decisions about their health.
Yes, and I hope people are aware that we do have options here in Canada also. If you feel like you're not being heard by your doctor, we can ask our family doctors to refer us elsewhere, either another doctor in that clinic or another clinic altogether or a different hospital, until we do find someone that does listen, because there are great doctors out there. They're far and few, but they do exist, and we just have to find the right one
I couldn't
and
agree more.
advocate.
Yeah. And getting second opinions is definitely on many of our journeys. And saying no to certain treatments that might not sit well with you, no matter what that may look like for you personally.
Yes, unfortunately, I had that experience once where a doctor wanted me on Lupron for the rest of my life, and I refused. And they refused to keep me as their patient because I refused to take that medication for the rest of my life. So that was actually what led me to going to California for endo care, for surgery, because I had lost my doctor here and they were not helping. And I was not okay to go back on the drug because I was on it many years before and had to be removed off of it because of how it was affecting my heart. So there was no way I would take the chance of going back on something like that.
And there you go. Here's like a valid reason as to why you would not want to stay on that drug. And the fact that they were dismissed and let go from their care is just a stark reminder of our healthcare system here. Doctors are overwhelmed, so they probably may have saw your case as well. They're not listening to me. I'll take them off my patient list, which is really unfortunate. But it did lead you to getting the care that you needed. So I'm happy for you.
Thank you. And then since coming back to Canada after the surgery, I've had wonderful doctors since then, like Dr. Lemos and Dr. Kivas, Dr. Brill. Like they're all terrific. They're all in Ontario. Sorry, I can't name everyone in Canada, but those are just ones that I saw here in Ontario, and they were really great. In fact, one of the doctors in Ontario is Dr. Leonardi, and he is in Australia this week, was sent in some recordings of questions that he has answered for us. So why don't we hear one of the questions from Dr. Leonardi?
The first question, is it possible to diagnose endometriosis without surgery? The short answer is yes. It is
Oh, I
possible to
don't hear
rule
anything. I
in
hope everyone else
endometriosis
does.
through imaging tests, including advanced ultrasound or MRI, that is done and reported by an expert in endometriosis. The longer answer, endometriosis imaging has been advancing over the past years to a point where we can reliably rule in deep endometriosis, ovarian endometriosis, and sometimes even the most mild form of endometriosis, superficial endometriosis, through imaging tests. Again, when it's performed and reported by an expert who has done advanced training in that imaging modality. One can also get a bit closer to a diagnosis through what we call the clinical diagnosis pathway, whereby if your signs and symptoms, particularly things such as cyclical period pain, non-menstrual pain, pain with intercourse, infertility or subfertility, should these things be in existence within you, then it can lead us to what we call a clinical diagnosis, though that is presumptive and not necessarily confirmed, unlike when imaging or surgery visually sees endometriosis with our eyes. But surgery is no longer required to confirm endometriosis if it is reliably diagnosed with imaging. It is not necessary to have surgery or even technically an imaging diagnosis to initiate medical or complementary alternative treatment options, as that clinical diagnosis can help initiate some treatment options to work on the symptoms.
Welcome back. So that was Dr. Leonardi, and he has a few questions that he has answered for us that we will play throughout the program. So beyond advocating, I know we do have some people asking about what we can do to create change in the system. And Michelle, I think you were telling me about some things that you've done that could try to create change. Did you want to share those with everyone?
Absolutely. So,
Great.
um, I advocacy is incredibly important, and we can get more into that later on. But advocacy is powerful. It ensures not only that your voice is heard in the doctor's office, but also valued. It's about making sure that your needs are acknowledged, not just as a patient, but with symptoms, but as a whole person. So that's incredibly important because each of us have our own unique experiences. Um, and advocacy can take many forms. And I've engaged in political conversations to push for pelvic health higher on political agendas. I've developed practical tools like printable symptom trackers and health planners and resources that are designed to help people living with pelvic pain. But I'm not all doing this alone. There's also uh, great organizations like Endometriosis Events. It's a Canadian charity founded by two incredible advocates, Tammy Ellis and Leah Haynes. who, like us, know firsthand the challenges of living with pelvic pain. And one of their key initiatives is a petition that urges the government, specifically the Ontario government, to invest in endometriosis education, research, and more accessible care. And the petition was developed alongside of MPP Dr. Jill Andrew, and it really describes the state of endometriosis care here in Canada. And it calls for the government to include endometriosis education in our schools, invest in research projects, and educate healthcare providers, as well as take action to improve that access to expert surgery and integrative care that so many patients are desperately needing. And beyond this petition itself, endometriosis events also host impactful workshops that don't just inform, they really do empower. So they amplify the voices of patients within our community here in Canada. They bring the real life experiences directly to healthcare leaders and policymakers. And together we're working to change the landscape of pelvic pain and endometriosis care through advocacy. And like I said, advocacy can look like many forms. It could look like political advocacy. It could look like self-advocacy. And a little bit later, we'll discuss more about the self-advocacy strategies that you might use to help you get the care that you need.
Definitely. Sometimes we don't realize, but we often have a library or churches near us, and we could even try to spread the word through there by making like maybe posters that we could pin up on a board just to give information so that parents and just people out there can learn so that they know what endometriosis is, so that that way if they come across someone that they love or themselves having the symptoms, that they will have an idea of maybe what it is. Because if you've never heard of it, and if your doctor has never heard of it, then it's going to be extremely difficult to get diagnosed. Luckily, more and more doctors are learning about it, but there are still many that don't know the symptoms and don't really know anything about it or how to diagnose. For instance, I went through that experience with my child of their pediatrician not believing the symptoms were endometriosis when she had clearly endo symptoms. And now she sees a wonderful gynecologist who agreed that that's what her symptoms seem like. And she is getting the proper care now. But we have to, like we said before, we have to advocate and we have to fight for ourselves and switch doctors if need be, if we're not being heard or if they're not aware of the illness or what the symptoms are or what it entails to have that kind of disease. Because we all deserve proper care in Canada, whether you're male or female, or whether you have a uterus or no uterus. You can even have this disease without a uterus, and many people don't know that. Sometimes people will believe that a hysterectomy is a cure, but it could travel to other organs, not just your gynecological organs. So you could still be left with it after having a hysterectomy, which is really unfortunate.
It, it's a whole body disease. I spoke to another individual in our community who got tested for her salivary gland. They took a biopsy and it came back as endometriosis. And she got the biopsy because every single cycle with the hormonal changes, she would notice painful symptoms occur. And she was curious, and luckily she had a doctor who advocated for her and said, sure, let's check it out. And it came back as endometriosis tissue.
Wow. I've never heard of someone being diagnosed that way, but that's amazing that they're learning new things and new ways to diagnose it.
Absolutely. And I also wanted to chime in. I have these posters, if anybody's interested. They're informative posters about endometriosis that you can put up in your local community centers, your libraries, your churches, just like
Even
Vicky was
work.
saying.
Mm.
Even work. Yes, I've had a lot of feedback saying that they put this up in like lunchrooms.
Mhm.
And the amount of people are like, who put that up? And people started to talk within the office of, similar symptoms and issues that they've been struggling quietly and for many, many years. So having pieces like this is also advocacy in your community, putting up these pieces. So doing something as small as this is incredibly important.
Definitely. Yeah, that would be really great to share at work so that everyone can learn, especially if you're a teacher, to be able to have that maybe in a lunchroom or in a back office, because a lot of teachers don't understand that children get chronic illnesses. It's not just adults, and it often begins as a child, but we don't get diagnosed till we become an adult. So they're suffering all that time, and the adults around them aren't aware. So sometimes they're not believed in school that they're not feeling well. Like I remember being pushed to do laps in high school gym class and the teacher would just say, "Oh, everyone gets their period, so it doesn't matter. You have to still run," and just
I remember
they
that
don't
clearly
understand.
too. I very much the 15-minute run, I think you had to run in order
So
to
we did a
pass.
mile, 4 laps around the football field.
They timed us. They're like 15 minutes, you gotta make it through the 15 minutes. And I was struggling. And many of those days I was on my cycle and there was just no understanding.
No, there isn't. There's a lot of lack of understanding within the schools. Like even with other, like with thyroid illnesses, like I have spoken with staff at my daughter's school, and even though teachers have gone through these things themselves, they're still not aware that it's affecting children also. So spreading the word through schools is really important because that's where they first will be learning about their period. And it would be great if they're also learning about what is healthy and that they shouldn't be in pain and how to ask for help, how to describe what they're feeling. Like all those things would help because sometimes when they're young and they see a doctor, they don't know how to share what they're feeling. They don't know the words of how to express. They'll just say, "I don't feel good," or "My tummy hurts," or just that's all and leave it at that.
Yeah, I couldn't agree more. I have two little nephews. Of course, they're not female, but they're not very good at explaining on a good day how they're feeling. So expecting a child to know exactly how to communicate with the doctor, and that's where a lot of parents need that education so they can be there to support their child through that. Yeah, it's very
Definitely.
important.
Yes. We actually have more questions from Dr. Leonardi. Why don't we take one of those right now? I know one of them was about children, but we'll just see which one we have coming up right now.
What steps can a patient take if their doctor or healthcare provider has dismissed their pelvic pain? Sadly, this is still a common thing. A lot of pain that is experienced by women and individuals assigned female at birth with diverse gender identity, these individuals' pain is dismissed. This is something that hopefully with time, with efforts through Endometriosis Canada, the Endometriosis Network Canada, we can really change, raise awareness of pain as a real entity that is often attributed to endometriosis, which is a real disease. But in the meantime, if it is dismissed, then I would encourage people to continue to be their own advocate. Don't let that dismissal result in you not getting care. Find alternative healthcare providers, if possible, either alternative primary care providers, gynecologists, and sometimes even healthcare providers in the allied healthcare professional space, naturopaths, physiotherapists, dietitians, can really help with validation, can help with initiating some treatment options that can help with symptom control. And sometimes as well, finding individuals who are not invalidating, who are validating and believe endometriosis, they can sometimes help point people in the right path from a diagnostic or alternative treatment pathway as well. So don't let that dismissal stop you from accessing care, even though that is a hard thing to do, to be your own advocate, especially when you are maybe experiencing severe pain, and that can be quite troublesome to navigate a healthcare system in that state. And together, as an organization, as a country, we will continue to advocate for believing people and this change from dismissive mode to a believing, validating mode.
We are so lucky to have Dr. Leonardi here in Canada. He is a wonderful doctor at McMaster Hospital. He's also been a great champion for endo warriors by trying to get change within our system, trying to create a multidisciplinary team like they have at his hospital, where you get all the different doctors helping to support you when you have it on various organs, as opposed to just having the gynecologist helping you, because we need a multidisciplinary team when it is affecting multiple different organs in your system. Why don't we hear another question right now from Dr. Leonardi?
How can parents best support their children and adolescent who are starting to experience symptoms that could be endometriosis? The first thing, listen and believe. These are the two most important principles. Pain is always real. Nobody is making it up for attention seeking. It is always a real entity. And people are not crazy, they're not making it up, it's not in their head, it is a real experience. So listen and believe. Next would be to get help through medical pathways. And that could be primary care providers such as family doctor or nurse practitioner. It could also be through a gynecologist. Now, in some communities, when it is a young person dealing with endometriosis-like symptoms, there are pediatric and adolescent gynecologists that may be accessible that would be able to help a little bit more in a way that's refined to that patient population, that age group. So a pediatric and adolescent gynecologist could be accessible in some regions, but not all. And if it's not available, then
Abby,
a
I think we
general
might have to go
gynecologist
straight
or an
to the doc.
endometriosis-focused gynecologist would be a good person to start to work with, start to implement strategies such as medical therapies, such as complementary and alternative therapies, sometimes surgery, although it is often not desired to have surgery at such a young age, or potentially having multiple surgeries over one's life course. So that's an individual approach and needs to be discussed with the expert. In that case, it would be an endometriosis-focused expert that would discuss surgery, as we do understand endometriosis is a complex surgical concept and is probably best done in the hands of those who have done additional surgical training.
Thanks for coming back, everyone. So that was Dr. Leonardi and with another great question. Michelle, we are going to be joined soon by Dr. Vidali, and we're going to be playing an interview that you did with our volunteer podcaster Lexi, who is wonderful, and she did an interview with you and one other group member from the support group, and we will be playing that after we speak with Dr. Vidali and get some Q&A. So if anyone has any questions, type those into the chat, and we will get those through to Dr. Vidali when he joins us. We really appreciate having you here, Michelle. We look forward to your interview and maybe even having another time where we chat for longer like this.
I would love that. Thank you for
Awesome.
having me, Vicki. This is a great opportunity to connect with the Canadian endometriosis community.
Oh, thank you. Well, it's time to celebrate us, right? Endo warriors, all the pain we go through, and everything that we handle on top of that. And you are one strong endo warrior. So thank you for
Right back
sharing
at
everything
you.
with us. Thank you.
Thank you.
So let's play one more question from Dr. Leonardi before we head straight to Dr. Vidali. Thanks, Michelle.
What steps can a patient take if their doctor or healthcare provider has dismissed their pelvic pain? Sadly, this is still a common thing. A lot of pain that is experienced by women and individuals assigned female at birth with diverse gender identity, these individuals' pain is dismissed. This is something that hopefully with time, with efforts through Endometriosis Canada, the Endometriosis Network Canada, we can really change, raise awareness of pain as a real entity that is often attributed to endometriosis, which is a real disease. But in the meantime, if it is dismissed, then I would encourage people to continue to be their own advocate. Don't let that dismissal result in you not getting care. Find alternative healthcare providers, if possible, either alternative primary care providers, gynecologists, and sometimes even healthcare providers in the allied healthcare professional space, naturopaths, physiotherapists, dietitians, can really help with validation, can help with initiating some treatment options that can help with symptom control, and sometimes as well, finding individuals who are not invalidating, who are validating and believe endometriosis, they can sometimes help point people in the right path from a diagnostic or alternative treatment pathway as well. So don't let that dismissal stop you from accessing care, even though that is a hard thing to do, to be your own advocate, especially when you are maybe experiencing severe pain, and that can be quite troublesome to navigate a healthcare system in that state. And together, as an organization, as a country, we will continue to advocate for believing people and this change from dismissive mode to a believing, validating mode. What are the most productive ways to advocate for endometriosis care across the country or locally? This can be multiple forms. Advocating at a very local level within your own healthcare team can be number one. It has been known that patients with endometriosis have educated their primary care providers and even their gynecologists about endometriosis. I certainly learn a lot from my patients, not that endometriosis is real or something that we can treat, but that it is, there are elements of endometriosis experience that you can still learn, even if you are an expert. So at the local level, really, continually educating your healthcare providers on your experience so that they understand the full scope of the disease. There can also be advocacy at a local parliamentary level, and the EndoAct Canada group has provided a toolkit for individuals to use that can reach out to their local provincial member of parliament, and that's a great way to continue to advocate on a larger scale. And then beyond that, raising awareness within your community through events, in the workplace, in your social circles, can also really help, as societal awareness of this really important and serious condition will ultimately help with people believing patients when they experience pain and validating and understanding the quite significant impact it can have on a person's personal life or professional life.
So, Michelle, tell me a little bit about your connection to endometriosis. When did you officially get your diagnosis?
I received my diagnosis officially in 2021. 2019. I had my first endometriosis surgery, and it was many, many years of pain and struggling to get heard and listened to by doctors and taken seriously enough. And it wasn't until I was 28 it wasn't until I was 28 that I received answers to my pain. I've struggled with chronic pelvic pain since childhood. It all started with a tobogganing incident. And I had tailbone pain that was never really resolved. And then I moved into puberty, and my periods became horrible. I actually had a chat with an old friend recently, and she's like, I recall you in grade 6. And I was like, ooh, I thought it was like grade 7 or 8 when the pain started. But she's like, no, it was grade 6, and you were beside a portable, and you were like, we were playing. And then all of a sudden you were like holding onto the portable in debilitating pain, not being able to say anything to me because the pain was so bad. And it was an emotional conversation with her recently. And so that really took me back, and I said, so my pain really started. So grade 6, how old are you in grade 6?
12 maybe.
12, yeah. So I've struggled with the painful periods. as well as chronic urinary tract infections and bladder pain, and struggled without really many answers for years. And it wasn't until, like I said, I was 28 that I ended up having my health deteriorate to a point where I was frustrated. Like I got to the point where I was angry that I wasn't getting the care that I needed. So I began my online search of what's going on with me because the pain was so horrible. And it led me down the path of endometriosis, which was something I thought of in the past that I brought up to my gynecologist, and they brushed it off and said, don't worry about it. You're not having kids, or, oh, we're not going to worry about it until like you're unable to have kids. And they didn't really understand the pain that I was going through and the suffering. But I did my research. I began to ask the right questions, organized all of my health records for over the years, and brought it to the specialist that I was able to get into because of the research I did. So I found the right specialist, and it was the first time I was really heard. And they said, we believe you have endometriosis, also possible interstitial cystitis and bladder pain syndrome, but we won't know until we have surgery. And I had surgery, it was visualized, it was removed. However, my pain did not improve. My bladder pain actually got a little bit worse, and my nerve pain got worse. So I was sent to another specialist and had my second surgery in 2021, I believe it was, where endometriosis was found on my pelvic nerves. It was found on my ureter. So a lot of work that the previous surgeon didn't have the same training as the second surgeon to do. So the second surgeon was able to help me out. And right now, I still struggle with symptoms. I was actually pretty much symptom free for about a year. Like I was doing really well, and then things started to go downhill again. So I'm actually on a waiting list for an MRI in this May. So hopefully I'll get a little bit more answers as to what's going on with some of my symptoms and my pain. But yeah, it's an ongoing battle. And I started the Happy Pelvis in, I guess it was, when in 2018, when my health really deteriorated, and I wanted to be able to talk with other people who were going through the same thing. And then it sort of evolved to, because people were asking me a lot of questions, like, were you able to get these diagnoses? And so that sort of led me to creating resources and a website to sort of help guide people in the right direction, because there is definitely a lack of resources here in Canada.
Tell me a little bit about that feeling when you had that appointment with the doctor who you felt finally listened to you and got the diagnosis. What was that like?
It was liberating, and like so many endo warriors, as we call them, like we don't want them to find something, but we do want them to find something because we want a reason and an explanation for our pain because we can't physically see it. So it was very validating and refreshing. It was quite different than previous doctors. Like I saw a urologist who did a cystoscopy because of all my bladder pain and UTIs, and he told me wipe front to back and I'll be fine, as if that was the problem. And like that was a really big piece of my journey. And I actually took part in an endometriosis study at UBC recently, where they're doing a storytelling approach where they're talking to people. And anyways, so that was my theme was white front to back, but it wasn't that simple. It was parametrial endometriosis. I had endo on my ureter. He didn't look deeper, right? Those doctors don't look deeper. They say, oh, you don't have this. Well, that's okay. Go to the other doctor. They'll help you. So it was very relieving knowing I was in the right place. I just wish so many others are able to get to that point, because it is an uphill climb.
What is one thing you would tell someone going through, maybe the early stages of their diagnosis with endometriosis?
I would say to not give up when you meet certain practitioners who do not take your pain seriously, and know that you're able to see another doctor. You're not designated to that doctor. You have every right to get a second, third, fourth opinion. Doctors don't know everything. We're all human. And just like I said, my first surgery, he was a specialist. He was able to identify endo and remove what he could, but my pain was still there. But there's always other doctors out there that might have a little bit more knowledge. And to not give up, because especially in Canada, things are changing and more specialists are popping up, which is really great to see, and hearing that they're doing the right training. So yeah, don't give up, because I remember feeling a lot of defeat walking out of the doctor's offices. So I think that's what I would share with them.
So Laurel, share with us a little bit about your connection to endometriosis.
Okay, so I'm an endometriosis survivor of 35 years that I've known of, as we all know that. I had a hysterectomy at the age of 30. I felt great after that. The reason for my hysterectomy, I bled for 3 years every day. I was constantly in bed. I had 2 young children to look after. I just couldn't do it anymore. So at that time, that was my only option. So that was 25 years ago. I'm now 55 years old. Moving forward to today, my passion towards my endometriosis sisters is humongous. And I think it is because I see so many stories that I can relate to. There's so many stories that I don't know about that I see. Just the drugs that are out there for endometriosis, and the misconceptions and the conceptions. And so today I sit here not knowing, do I still have endometriosis or do I not? I have many autoimmune issues that they call, what are they, IBS and arthritis, and I could go on. I struggle mostly with gut issues, a lot of scar tissue lesions from endometriosis. So to date, I may not have endometriosis, but I have the floating contents, I call it, of endometriosis inside of me. So what caused this? Endometriosis. I'm here. I'm not big into the endometriosis community, but I'm here to share my story and hope it helps others. And to bring in the future someone I can share my story with that is compatible with my story, because I don't have that community that is where I am today. So I struggle with that. So I'm looking for that community. There's so many young women out there, young girls that struggle. It just blows my mind. So in sharing my story, I really hope it brings hope to others. I'm 55 years old. I've lived through all of it. And I'm here to tell my story. And I'm still going through it. And there are days that, you still just want to give up. I have a great support team great support system. My parents are very supportive. My husband is my number one supporter. He's always by my side. Even when he tries to be and I kick him away, he doesn't go away. So, I mean, to the point, that is my story. I've had surgeries. I've had hospital stays, hospital beds. I did good for 4 or 5 years, and then I think, you think you're out of the woodwork, and you're not. But just
What
hold.
was it like? What was it like getting a diagnosis that long ago? Give us a bit of the context. Like, how did that happen?
So I remember from a young age always having tummy aches, always. And my mom would always say, Laurel, you're under stress. Like, you're stressed out. Like, I'm 5, I'm 7, I'm 10, I'm 12. What stress? But again, my mom knew nothing about nothing. Like, I didn't get a period till I was 17. I got one when I was 13 for like a half a day. I was so excited because all my friends had their period. And I'm like, oh my God, I got mine. Well, I had it for half a day. Then I didn't get it till I was 17 years old. So doctors say that was normal. It was normal. It was normal. I went to several doctors. Like, I can't list them all. Finally, we had a doctor come into Flin Flon, which is northern Manitoba. We don't have a lot of stuff up here. So I was lucky to come across a doctor that came in from across country, South Africa, actually it was. He diagnosed me. He said, you have endometriosis. I went, what? I have what? I knew nothing. I never heard of it. I didn't know what it was. Like, what is this? He says, you can't have children. I'm like, I have one. Sorry. But in saying that, I didn't know I was pregnant with her. I was diagnosed shortly after I had her from birth, about a year after. So I was 20 when I had my first child. So I was diagnosed at 21.
Wow.
So, and going on from there, I was with 3 different gynecologists, which I was very lucky to find one that didn't have the greatest bedside manner, but I loved him to death. He was so honest, truthful. We did try many things. I was a guinea pig, is what I called myself, like many of yous out there are. Yeah, so that was how I was diagnosed, and here I am today.
Well, I feel like there are others out there like you, maybe in the same position, struggling with these chronic conditions or autoimmune that maybe didn't even know they had endometriosis. My grandmother, similar, bleeding all the time. They did a full hysterectomy at 26. My mother, similar situation, full hysterectomy at 27. And based on my uh, experience with endometriosis, my sisters having endometriosis, it's likely they did too, but there was no intervention or diagnostic thing for them. They just took everything out. So I hope you can find those people that have a similar story to you. But for the girls, the young women going through this, what words of wisdom do you have for us?
Oh boy. That's a really tough one, and I think of that often. You know what? Stay strong. Stay connected. Be truthful to yourself. That is probably one of the biggest things. Be honest to yourself. When you're hurting, you're hurting. When you can't eat, you can't eat. When you can't walk, you can't walk. When you can, give her, man, do it. Because you can do it. Like, give her all you got. And never give up. Just never give up on yourself. Others might. You'll have many that do. Many. But don't give up on yourself. you're worth it. Every one of you, for sure.
One of nerves and endometriosis, because I think it's something relatively novel, and we're developing a novel understanding on how there is an interaction between the nervous system and other systems, and also in how disease can position itself in the middle. Okay, and this is why I'm very interested in this area, and I call it, it's called not commonly, but neuroimmunology, because the immune system also plays a big role. So you have this interaction between the interplay between the disease, in this case endometriosis, the nervous system, and not just the nervous system. As as people may be aware, there's different types of nerve fibers. There's the somatic nerve fibers, right, which are responsible for, like, for example, our perception of pain and temperature and things like that, right? And then the motor nerves, right? And then you have other nerves which are not responsible for those activities, but more for organ function. Okay, and as you may remember, maybe from high school, that you have the parasympathetic system and you have the sympathetic system, and the vagus nerve is the most important nerve, is a 10th set of nerves, like the nerves, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The vagus nerve is probably one of the most important nerves because it's responsible, is the big parasympathetic nerve. Okay, and the reason why the vagus nerve is important is because it's a very important nerve, and it plays a very important nerve in inflammation, and it has a powerful anti-inflammatory activity. And when the vagus nerve doesn't function properly, you start having problems. Even at the level of the bowel, you start having gastrointestinal problems, a lot of that swelling. You could have increase in inflammation, and also you could end up having some cardiovascular type of effects. Other nerves can be responsible, but so why does this happen? Does the disease have to be specifically on the nerve? The answer is no. What happens is that you don't really necessarily have to have disease on a nerve. So, because if the nerve behaves abnormally, sometimes just increased inflammation, or also central nervous system type of phenomena, because we know that whenever we are in pain, our central nervous system starts acting also abnormally, and then you end up with abnormal function of certain nerves. So what happens in these cases is that misbehavior of the vagus nerve is associated with this phenomena. And this is why you see emergence of certain therapies now that are focused on, for example, stimulating vagal activity to reduce inflammation. You have all those, you have intra-ear vagus nerve stimulation. You may have heard about that, or devices that you place on your neck to stimulate the vagus nerve. And these have powerful anti-inflammatory activities. I mean, powerful if you do it right. I think a lot of it, you need to have a lot of discipline to do that. But overall, I support the science behind nerve stimulation and inflammation. But there's more. One of the doctors of our group, Dr. Marcos Ocali, who is a professor at Columbia University, has just completed a phase 1 trial of pre-sacral nerve stimulation for the treatment of ulcerative colitis and Crohn's disease with pre-sacral nerve stimulator. This is a little gadget that you put in the pre-sacral nerve, meaning, sacral nerves, foramens 1, 2, or 3. And stimulating these nerves, believe it or not, has the potential to cure ulcerative colitis and Crohn's disease. It's an incredible progress. It just blows me away what we can do now. And of course, this is just phase 1 trials, but what you could see is that where the direction is going of of therapies that are not directly that treat the condition indirectly by manipulating the nerves. And why do the nerves stimulation improve bowel function in this case, or in bowel inflammation, is because they modulate function of inflammatory cytokines, more specifically mast cells, and which secrete these cytokines and then cause the inflammation. It's fascinating to me because when it comes to endometriosis, I believe that the future of endometriosis treatment is not going to be surgery in the next decade or so. I believe it's going to be, and it's not going to be a hormonal management, because hormonal management we know is, and you were talking about it earlier with your prior guest, hormonal management is very limited and carries its own problems. By the way, one of the reasons why many patients, people with endometriosis, develop Crohn's disease and ulcerative colitis, because there is an association between birth control pill and ulcerative colitis later in life. So, so I believe the treatments are going to be focused. The new treatments are going to be focused by the immunomodulations, nerve modulation, and um, eh, eh, and other immunotherapies. So I see the future in that direction. So I think it's just something that I find very interesting. And I'm glad somebody asked that question, because it's my interests now are really focused on this area of nerve stimulation, believe it or not. I'm very, very much interested in that, and uh, there's so much innovation going on in that area. It just has to be applied directly to endometriosis, but it will.
That's really exciting to hear
Sorry if I
because
was very
over
winded, but I'm very
no,
fast.
no.
I wanted to say new things to you today, new stuff.
That's
I'm
really
tired of people
exciting what
just
you just
coming on
told
and
us.
saying excision, 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 excision.
Yeah, and the thing that we've heard the most over the
I mean,
last
we all know
decade within
excision
the
is
group is we're
important.
tired of hormones.
Yeah, yeah. I think, look, hormones are all, I think you're saying that earlier, but it is a very rough tool. It's a raw tool. We want more like focused tools. We want tools that don't have the side effects. We want actual treatment. We don't want symptomatic treatment. Although another thing that I've seen now, at least one thing that I'm pretty excited is that the FDA just approved a new pain medication, which is a non-narcotic medication last month. And I forget now the name of the medication, but and I have no association, no financial interest, none of that. But the company is called Vertex Pharmaceutical, and there's a new.
Oh, sorry, everyone. We got disconnected. We are going to try to get back with Dr. Vidali. For now, let's hear one more question from Dr. Leonardi.
Is there a connection between endometriosis and other health conditions? The short answer is yes. There are associations between endometriosis and other health conditions. The long answer is that endometriosis is highly associated to certain gynecologic conditions such as adenomyosis. Me and my team at McMaster University are working on research to understand the potential connection to polycystic ovarian syndrome, PCOS. But endometriosis has been connected to lots of gastrointestinal and bladder-related symptoms and issues. It has also been connected to other diseases such as autoimmune diseases, cardiovascular and cerebrovascular diseases. And we don't understand why it is connected so extensively to other diseases in the body. Is this a genetic link that individuals with endometriosis are predisposed or at higher risk of having other conditions as well? Or is it that endometriosis as an inflammatory condition leads to some of these other downstream health issues as well? These mysteries are still remaining unsolved and do require a lot of research, which comes back to the previous questions around advocacy for advancing research in endometriosis care is incredibly important because there are so many mysteries that we do not have answers to. And those answers may allow us to advance endometriosis care, both from a right now, how a person is experiencing endometriosis and their symptom management, as well as how can we better help people with endometriosis in the long run with other health conditions that endometriosis may be associated to. So lots of mysteries remain, and we will solve them through advocacy, through good quality research, and enhanced clinical care.
Okay, we're just going to head to our next question right now. So, how much is enough when it comes to surgery treatment going forward, especially for women that already have had surgery and have issues facing excision? Or they have problems with adhesions from having excision surgery. So, how much is enough when it comes to that?
Well, I think that it's a very good question. It's a broad topic. The question is surgery. I think there's different scenarios, right? You can't just say there's just one scenario. There are people who have had surgery, proper surgery, and they feel well for a long time, for a long time. And then one day they feel, oh, it's like the endometriosis, knock, knock, I'm here again, And sometimes it's not a major pain, but it's just a reminder of the pain that was there before, right? And it's like, oh my gosh, it's back. So, and then there's people, for example, who have had the surgery, but then never really got complete relief. That's another example. And so I think we have to break it down into the different circumstances. I think that in order to assess this scenario, one has to understand what the actual problems are, the location of the problem. If it's pain, what kind of pain is it? Is it central pain? Is it associated with the periods? Is it all the time? So I think we need to break up that aspect, right? To have a better understanding of what the pain generator is. Other people, for example, have a lot of bladder symptoms. So, is that what needs to be addressed? Is it the urgency, the frequency? Maybe the doctors did not address that at the time of the surgery, so now you're dealing with that. The third problem could be ovulatory type pain. That can be, in my opinion, more associated with adhesions. Another problem could be bowel pain. If there's significant pain with bowel movements or evidence, that may be suggestive, or severe constipation or diarrhea, sort of like functional problems. So I think one of the things we need to address is what to do after surgery, how to assess what's going on, as opposed to looking at it's back. I think we need to actually break things in pieces. But one of the problems with that I see with a lot of practitioners is that they do the surgery and then you're on your own, right? They're like, oh, I did the excision, now figure it out. And then one ends up going to the gynecologist, and the gynecologist say, hey, go back to the doctor with the surgery. And why are you back at me now with all your problems? So you have this ping pong, right, between different practitioners, and the patient is left in the middle. So this is why I think a multi-specialty type of approach to this disease is very important. Looking at the urological element, looking at the gastrointestinal element. I think that surgery is just one of the tools, and unfortunately, all we hear talk about here recently is just surgery, 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 surgery. And all right, we get it. Yeah, excision, fine, we get it, but I feel that there's a lot of doctors that all they want to do is just the excision, but they don't want to do the follow-ups. They don't want to deal with what's happening after, or they don't know how to. I'm sorry to say that, but I think that's one of the big dilemmas there. And so I think there needs to be more educations for doctors Certainly neurology. Urology is a big one that doctors don't know how to manage these things. And on the gastrointestinal sides as well, there's like a lot to be managed there. And I personally manage, a lot of these people that there's a lot of things that I do, trying to manage for example, the MCAS, the mast cell activation, some of the GI issues, the bladder issues. I think that's what's going to be addressed. If the only thing you do is you take the patient back for another surgery, you could definitely make things worse. There's no doubt in my mind. You're not going to find a lot of disease. Last week I saw somebody who had some ridiculous number. I want to say 9 surgeries with the same doctor. I mean, it's
Wow.
almost criminal. In fact, it is criminal. The doctor lost their license. It's not criminal, but it's certainly severe malpractice. And I was like, how is this? What's wrong with this doctor? Like why? And there are people that are, sort of definitely victims of bad medicine. We have to accept that. So yeah, I mean, I think that an in-depth analysis by system is what needs to happen. And in some cases, the question was about adhesions. Adhesions can be a factor. Actually, I just put a video on my Instagram about that. Or the Dr. Bagaria, one of the doctors, one of my colleagues, put it up. And we all saw somebody, a young person who had like ovulation pain, and indeed the ovaries was kind of stuck there. The problem is that, okay, you go in there, you do the surgery, you detach it, but is it going to get stuck again? Like, what are you going to do to prevent it from getting stuck again? And that's another thing. How do you prevent adhesions properly? I think a lot of attention has to be placed on these things. It cannot be done. Surgery should not be done lightly, should not be taken lightly by neither by the doctor nor by the patient. That's what I think.
Mhm. And what you said about patients being left or just like abandoned after surgery happens so often that once someone will have excision surgery, they'll maybe have a follow-up and then the doctor no longer sees them again. And then weeks or months later, their symptoms, they might not be as severe or they might have new symptoms appearing and then they don't know who to go see because that doctor no longer sees them because they're finished with them. But let's
Right.
just head to our next question here.
I think
Um,
that's BS. I think that's BS, by the way. I think that should not happen. That's not good medicine. You understand that? And I think one of the reasons is that we don't really know who's actually good because there's no um, monitoring of outcomes, medium or long term. It's all what people say. Oh, I have good outcome. Like there isn't like a real standard, and all these certifications that are out there, they just measure your ability to do a decent surgery, but what is your long-term outcome? How are people doing long term? And actually, I'm starting a program now where we're going to monitor people long term and publish the results. So we're actually working on that with Dr. Mauricio Brau from Brazil, who's the number one, and Dr. Ceccaroni as well. These are the people who have probably published the most in this area. They have like hundreds of publications in this area. So we want to generate a new standard where it's not just doing the surgery, but what is your medium and long-term outcome like? So we're hoping to make a mini revolution.
oh, that's awesome to hear. Okay, our next question we have here is, can endometriosis cause sciatica nerve or leg pain? And if yes, how can it be treated?
100%. And this is part of a chain of effects, right? What happens is that when you have endometriosis, you develop pelvic floor dysfunction. And when you have pelvic floor dysfunction, what pelvic floor dysfunction really means is like the muscles of the pelvis start misbehaving. They can tighten up, they don't relax. And what happens is that sometimes these nerves, these muscles end up compressing the nerves. When the muscles compress the nerves, then the nerves start firing. And when the nerves start firing, you develop pain. The sciatic nerve is a quintessential example of that because of its position, especially when you have a lesion that is posterior, in the uterosacral ligaments or even more lateral, as long as the lesions are 3 centimeters from the nerve, then the nerve starts firing. That doesn't mean the disease is on the nerve, but it's proximal to the nerve. So what to do in those cases? It's tough because sometimes it's not enough just to remove the disease. Then you have to start, implementing physical therapies and other therapies so the nerve stops firing. And nerves are weird. It takes a long time when the nerve starts firing in a bad way. It takes a long term for the nerve to come down. It could be months. So it can be very frustrating and very, very unpleasant. And there's a lot of suffering because of that. But 100% that happens. Yes.
Okay, yeah, that sounds extremely painful. I feel horrible for anyone going through that.
It's
Um,
sad.
we've had
Mhm.
many people in the recent months bring up EndoSure. It recently came to my attention. I'm not sure if you're aware of what EndoSure is, but we do have a question on your thoughts on that. It is
No,
a
what is Endosure?
non-invasive, it's a non-invasive diagnostic tool meant to diagnose endometriosis, sort of through like waves, kind of
You mean the
like
saliva test? The saliva test?
nope,
The
this is
saliva
one where
test?
they put kind of like patches, almost like when you wear like a heart monitor. They put patches on you
Yeah.
and they can read it through the patches. I'm not sure of everything, but it's done with wearing the patches on you,
I'm not
almost like
familiar,
having an ultrasound.
Yeah, I think that, I mean, look, I'm not familiar with it. Any new potential diagnostic tool, I find it interesting. So not knowing much about it, I don't want to comment on it. There's also a saliva test
Mhm.
now, by Zweig Pharmaceuticals. I think that any of these tests are useful. Ultimately, though, for me, the ultimate diagnosis needs to come from multiple sources, like because I think that basically you could get to probably close to 85% of ability to predict just by having a good questionnaire. You know what I'm saying? So a lot of these tests are offering you 90%. I mean, what's the difference really? You know what I'm saying? Like most of the people I see, just by talking to them, I know they have endometriosis. So what is the test going to say? Like, okay, let's say the test is negative. Are we not going to do anything about it? I don't know. Like I still think that you need a good ultrasound, good imaging. I think a lot of these tests are really screening tests, right? They're screening for the disease. And, certainly microRNA is very, very useful. And that's what the saliva test does. And, we know that it's a good test. But ultimately, I think just like any screening tests are just screening. And that's on the assumption of an asymptomatic person, right? But that's the difficulty with all screening tests. Like I think that's why we have a lot of problems with that. Like even a mammogram, even if the mammogram is negative and you're suspicious, you're still going to move forward and investigate further, right? I think that's really what it is. And most mammograms are done on asymptomatic people, right? Because they're screening tests. So when a person is symptomatic already, I think they are beyond the screening test. That's my opinion.
Okay.
It's a little bit different for the fertility patient because the fertility patient sometimes is asymptomatic, sometimes. So maybe that test may be useful for them. But when you're symptomatic, what are you doing a screening test? You already passed the screening, you're symptomatic. You got pain with menstrual period, pain with intercourse. You know, I mean, you got a positive ultrasound. What is the screening test for, really?
What I hear often in the support group is from people that have had endometriosis diagnosed through surgery, but yet it doesn't show up on the ultrasounds for so many people. Is that just because of maybe the technician not knowing how to find endometriosis, or is it the certain ultrasound machines are more equipped to diagnosing it?
It's a combination of the two. Obviously, the tool is important. Good ultrasound machines are better, but that's just logical. Uh, Skill is extremely important. You were just talking with Dr. Leonardi, who's a very good ultrasonographer. I'm a very good ultrasonographer myself, actually, because I don't know if you know this, but I'm also a fertility specialist. So I perform, you know, tens of thousands of ultrasounds myself. But the problem with small superficial lesions is they can be tricky to be seen, and you have to do a very slow, careful ultrasound, take a long time to do it. And what I've seen is that a lot of doctors just don't see these lesions, so you can't really. A negative ultrasound yet is not, in my opinion, done generically is not a good test yet. What I don't understand, you see, the problem is that, especially in Europe and to some degree also in Canada, 100% in Europe and also some degree in Canada, a little bit less in the US. If you have a negative ultrasound, the doctors refuse to operate on you. And I think that's BS. I mean, ultimately, what's the damage for having an ultrasound where they're looking? And if they see the disease, they remove it. I just don't see the negative in that. I just cannot see why not. Why leave the doubt? When you don't have 100% certainty. In my opinion, it's certainly, if somebody's symptomatic and there's a high index of suspicion, it's certainly worth a look and removing the disease. But I know that I go against some of the opinion of the big organizations, which are like, negative ultrasound, it means you have no endo. I disagree with that.
Okay. Well, thank you. Let's catch up on some of the other questions we have popping up here. For us in Canada, we have to endure long waiting times for a specialist to treat us. What is your opinion of nerve blocking to help manage pain while we wait for treatment?
I am in favor of nerve blocks. I think that uh, nerve blocks, Botox can help at least work with pelvic dysfunction. Uh, and I'm also very much in favor of physical therapy, acupuncture, because sometimes any one of these treatments can contribute to some degree uh, incrementally to improving the problem. Ultimately, though, what happens is that if you don't remove the offending problem, the pain will come back. But if you can get a nerve block, I would say do.
So I believe you're calling in from a cell phone, so it might just be getting heated. Is it working okay right now? Wonder if we could hear you. Okay, we'll wait and see if we can get that fixed up. Um, so we'll just give that a minute, but we do have some great questions coming in. If anyone else has any other questions, please send them in because
Hey,
even if they don't get answered today, we will get to them. Hi, thanks. So glad to see you again.
hey, here I am. Sorry about
Uh,
that.
that's okay, no problem at all.
I was saying the other benefit of the nerve block is that if you, by blocking certain specific nerves, whether it's pudendal or ilioinguinal or any other nerve, uh, you get a better idea of what the nerves are involved. So that helps also in a diagnostic perspective.
Okay, thank you for that information. That is good to know. Yes, I've had experience with nerve blocks, and I know they can be wonderful, but they don't always help for long periods of time, or at least not in my
No, they
experience.
don't. Mhm.
Let's get to the next question. We have here, can any abnormalities in blood clotting, such as an altered APTT, be linked to the development or progression of endometriosis?
I don't think there's any clear evidence of that, to be completely honest with you. Um, I don't think some people are thinking, uh, that, but I don't think there's any scientific evidence to that. No, I don't think so.
Okay, from that same person, it's continued, and they've asked if it could cause, if there's any association between clotting disorders and imbalances of inflammatory or angiogenic processes involved in the condition.
Look, it's a hypothetical. Angiogenesis is not really related necessarily to clotting. They're two sort of separate mechanisms. So I'm not really convinced that there's a link there. Ultimately, inflammation in general can cause some level of angiogenesis, inflammatory changes. So I think it's more like an inflammatory process than a coagulation process.
Okay. Our last question that we have up right now is what combination of tools would you recommend for an endo patient to use other than excision surgery and hormone therapy for long-term endo care management? I know you mentioned physiotherapy, acupuncture. Are there any other things that we can do to help manage long-term?
If there's bladder issues, those need to be addressed. There are some bladder medications which
Oh, I think we lost him again. Sorry, guys. We will try to get him back for that last question, and then we're going to see our wonderful pet collage. Thank you to everyone that sent them in. They're all adorable. And now let's welcome Dr. Vidali back. Hello.
Oh my God, I'm embarrassed. I'm actually upstate New York, and here the connection is not the best. I apologize.
That's okay. We're just
So
thankful
I
to
was
have you
saying,
with us.
when it comes to the bladder, I think there's medication for the bladder that actually work quite well. You cannot imagine how many people have bladder issues that are unresolved and unaddressed. Urinary frequency, retention, um, burning. The list goes on and on. And I think that sometimes that can be a major part of the problem. So I think that part needs to be dealt properly. Unfortunately, urologists are not very good at dealing with these types of problems. But I think, because they're not interested. They like to take care of, old men with prostate problems, urologists, for some reason, like it's just, you know, um, but I think, like I said, medication, and sometimes nerve stimulation in specific cases can be extremely helpful. What I like about nerve stimulation is that it really helps with both the bladder problems and also with the bowel problems. It can help a lot with the chronic constipation because I believe that some patients with endometriosis, I observed that some patients with endometriosis have these additional problems. There's a propensity for these problems. They have particularly sensitive nerves that have like an exaggerated responses. Many of these people that I see, some of them have had chronic constipation from way before they develop endometriosis. So I think that addressing these problems is very, very important. It's a very good complementary approach to this. So part of it is though that there isn't like FDA approval for the bowel indication for presacral nerve stimulation. There's only for incontinence, but not for constipation. But constipation will come very soon. I gotta tell you that. I have treated young women, teenagers who had chronic constipation with nerve stimulation. And these are people that maybe had a little bit of endometriosis, but really the big problem was like a nerve problem. And uh, a lot of surgeon went around digging around and, maybe causing more damage to the nerves, because let's not forget that if you damage those nerves in surgery, you can create chronic constipation problems. So I think that looking at that from the perspective of the nerves, I think is very, very important. The real issue is that how do you manage the adenomyosis? And because, especially for younger people who are interested in reproduction, you don't want to have invasive and demolition techniques. And for that, now I'm actually implementing management utilizing uh, uh, um, microwave or ultrasounding ablation. And I know ablation is bad, but for adenomyosis, it's good, right? Because it's like really a probe that we put into the uterus, and we kind of like ablate the lesions. And it's really wonderful technology because it doesn't require cutting in the uterus and damaging the uterus. It doesn't require embolizations. Which can
Wow.
also embolize the ovary and damage the ovaries. So like it's a new technique, and it's very, very good, and can be done under sedation, transvaginally with a needle. So it doesn't require like open surgery or anything like that. So right now I'm working on these new techniques, and they're quite good, actually, I have to say. So that's one area where a lot of people have the endometriosis surgery, but they're left with the pain because of the adenomyosis. So I think that something new and innovative that's out there for people, which I think is very, very good.
Yeah. More new non-invasive treatments are always welcome. That's wonderful. We'll
Right.
take one more
Yeah.
question because that's all we have time for. We have, what are the risks associated with having endometriosis involving the sigmoid colon? And while we wait for treatment.
Well,
So,
the the disease itself, well, it said the sigmoid and not the rectum, right? So I think the question is about something further up, you know? And I think that whenever the closer the lesion is to the anus, the more it's going to present symptomatic earlier, right? Because you feel it there. When a lesion is further up on the sigmoid, what happens is that sometimes it grows silently for a long time, and you get that bloating feeling, and the bloat. As the lesion gets bigger, what happens is that when the poop arrives there at the lesion, what happens is that it stops for a little bit, because there's like impaired mobility. It's not really an actual stricture, it's impaired mobility mostly. And then it goes down, and people have to run to the bathroom. So the typical symptom of a high lesion of endometriosis is bloat, you feel a lot of pain, and then you got to run. That's like the typical thing. And sometimes you can't even make it to the bathroom, it's that bad. So because you basically, the poop gets all of it gets into your rectal area, in the rectal ampulla, very quickly. So that's really what happens with people. It's very unpleasant. So I wouldn't call it a risk, but that's kind of the presentation. And the risk is more that it stays there indolent, growing for a long time, and it can be very, very, very unpleasant symptom when it gets bigger. But unfortunately, that's only treated surgically and sometimes with a bowel resection. But the good news is that they heal better when you do surgery, because the higher the lesion, the easier is the healing, even if you do a bowel resection. The lowest the lesion, the more laborious the healing is, because it's closer to the anal canal.
are there specific treatments that are available for adenomyosis, or is it just like you had mentioned, the ablation on the uterus?
I think this new treatment that I'm doing, the ablation, is very, very good. And it actually works. I have dabbled, I want to say dabbled, not dabbled, but I've done some treatments using Botox on the uterus. And I haven't really had amazing results in it, but maybe I haven't done enough cases of it. That's just preventing pain. It's just a pain treatment. And unfortunately, for adenomyosis, you got to stick to the old hormones, like, unfortunately, for adenomyosis, Visan is your friend. As unpleasant as it is, but either that or um, norethindron acetate, those are the things. But I'm very supportive now of the ultrasonic or the microwave ablation of the lesions, because you basically you're destroying them, and that actually has tremendous symptomatic improvement
Oh, well, that's wonderful to hear. It's always
and
exciting when
preserve
there's
fertility and preserve
new info.
fertility.
That's the
Yeah,
most important thing to so many people, so that's wonderful to hear.
of
I know
course.
there's a lot of
Yeah.
women wondering if they should be having surgery before they have before they try to conceive, or if they should even be waiting to conceive it. Like, which would you recommend? Because we've had many in the group wondering if surgery is better before trying to conceive, if they do need excision, or if it's best to wait till after having a baby.
I don't think there's a specific answer, right? The question is, can you get pregnant? If you can get pregnant, why not? You know what I'm saying? Like, and then you'll deal with the problem later. I think a lot of it depends on the ability to conceive. So I can't give an answer just like that. I think it's like for fertility and endometriosis, it's really on a person by person basis. It's not like, oh, it's there, we got to do surgery. I think it depends on the circumstances.
Okay, so if they're able to get pregnant, then you would recommend that they try, but if not, then maybe
Of course.
consider. Okay, well, that's good to
Yeah,
hear. Thank you for all
absolutely.
this wonderful information. We are so lucky to have you with us today. We thank you so much for your time, especially on a weekend. Thank you so much for everything.
Oh, my pleasure. Thank you for having me. Thank you very much. And see you very
Thank you.
soon. And I will post this on my Instagram to share with people so people can see it. Thank you very much. Bye bye. I love the pet video. Fantastic.
Thank you. And thanks to all our volunteers as well who helped make this possible. Our volunteers are truly dedicated to helping our support group and helping all the events go on. So thank you to all of you that helped. And Lexi, thank you for doing the interviews as well. And see all our adorable pet videos. Thanks for watching.